60. So when we'll start tapering and her dose is to 10 or 15 milligram per day, we can stop. And this is to prevent
PCP, sir. Pneumocystis pneumonia.
Zero now.
Yes, sir.
Do
Pneumocystis
you
pneumonia.
also use Septran prophylaxis for cyclophosphamide rituximab?
No, sir.
No.
We don't use.
No. Sit down. Vaccination in nephrotic syndrome. Pediatric, any pediatric resident can say. We said no, infections are common. We may not be practicing it, but can someone answer?
So, pneumococcal vaccine, then varicella vaccine, influenza vaccine.
Very good. And don't use live vaccines. Sit down. When to consider genetic testing? Akash, you answer. Finally. We did it in this patient.
Sir, in a biopsy, if we are getting FSGS, then ideally, everybody has to be tested.
Not every FSGS.
In FSGS.
Not everyone. Now, narrow down your.
When we have familial cases of nephrotic
familial
syndrome.
Cases.
Yes, sir.
When they have nephrotic with dysmorphic features.
Yes.
And in FSGS, when it is steroid resistant.
Steroid resistant FSGS.
Okay. And in this child, why we did? She responded beautifully. Ultimately, she was your case. Huh?
So
why we did? We asked for genetic testing because she presented at what age?
9 months of age.
9 months. You know, someone said usually present at 3 or 4 years of age, but in first year of life she presented. Sit down. So these are the indication. Continue.
Her whole exome sequencing was done.
And was negative. Okay. So it didn't contribute. We were expecting something, but.
Sir, on follow-up after 1 month, her anasarca has resolved. There was no pedal edema. Her weight has reduced from 84 kgs to 54 kgs, a weight loss of 30 kg over a period of 1 month. Her urea and creatinine has improved to 32 and 0.5 milligram per deciliter. Her 24-hour urinary protein has come down to 200 milligram per day. Her lipid profile has improved. Her albumin is now increased to 3.2 milligrams per deciliter.
Within 1 month. Now she is behaving like a steroid sensitive. Okay. Continue.
She's planned to be followed up on OPD basis with a plan to be tapered off steroids and follow up for proteinuria and relapse and watch for steroid side effects.
So we come to the conclusion. We wanted to discuss approach to a case of nephrotic syndrome and emphasizing on use of diuretics and albumin and discuss various complications of nephrotic syndrome this patient didn't have. That's the end of today's session. Any questions from residents? Vikrant? Because it is more sensitive. It is the first protein which is filtered whenever there is an injury. It has not come into our clinical practice because it is not widely available and all the guidelines are following protein. It is more sensitive.
In patients of hypertension, the serving soldiers, we gave opinion.
Yes, that is what has come into that GFR now. We should be using albumin. In diabetics also albumin, but for nephrotics, it is not that commonly available. You will not get it in your zonal or peripheral hospital. You are in FMC and command. That is why you are getting. So practically PCR can be used. Best is albumin, no doubt. Any comments from Abhishek? You wanted to ask, please. Just after this, sir.
So regarding the use of diuretics in these cases, sir. Sir, generally the oral diuretics may not act because of the gut edema which is there. Sir, in case of parenteral loop, when we are giving diuresis, sir, so whether we should follow a bolus regime or whether we should follow infusion regimen in these cases?
Both are effective.
Both are equally.
Okay. So, but never give a bolus as push. Otherwise, it will make the patient deaf. And same applies for albumin also. You can give a bolus and after that start using diuretics. It is center based or what you have been, where you are trained actually. Bansal sir.
Very well discussed, Colonel Chauhan. I had just 2 points to make. This patient has been a case of nephrotic syndrome who has been on multiple courses of anti steroids since very young childhood. So we should always do a workup for osteoporosis, as mentioned by one of the pharmacology residents. Second thing is, which has been missed, is since this patient was young, received steroids. So it is most likely that the growth also must have been affected. So there is now indication of using growth hormone in patients who have chronic kidney disease or nephrotic syndrome. If the growth is affected, receiving multiple courses of steroids, I think the growth should be charted, growth chart should be made, and if indicated, growth hormone should be used in these patients.
Thank you, sir. We'll assess that.
Sir, in continuity with what Bansal sir said, sir, are we doing thyroid profile in all the patient nephrotic or we have some
No,
selective?
we are not doing. On ground, we are not doing. Should we? You suggest
Yes,
so?
sir. The thyroid dysfunction is fairly common.
Okay.
In fact, not only because of the proteinuria and like PLPA2 presence also says sometimes that there may be association of thyroid dysfunction. Thank you.
We'll consider. Yes, please. Varun.
Very well discussed, sir. Just to address the question of adequacy that you had asked, sir. Number one is to rule out FSGS, we need to examine at least 20 glomeruli. If on examining 20 glomeruli, it's considered a representative sample, we don't find an FSGS, we call it as minimal change. Otherwise, we call it non-proliferative glomerulopathy, and possibility of FSGS cannot be excluded. Now, this adequacy varies with different situations. So, for example, if we have to do scoring in a percentage of glomeruli, then we require at least 10 glomeruli. So for example, if we want to do IgA-MS scoring, we need at least 8 glomeruli. Similarly, for transplants, we need at least 10 glomeruli. So that is that. So it varies with different situations. The second is the recent evidence, the recent body of evidence regarding FSGS, which is steroid resistant, is in the form of anti-slit. There's a recent article in Kidney International, sir, that says amongst the circulating factors, there's one other addition, that is anti-SLIT4 antibodies, which are actually anti-nephrin antibodies. They co-localize with that nephrin molecule. And these patients, they tend to present early, and also they have better response to the second line therapy in nephrotic syndrome. So this is the recent body of evidence that I wanted to add. So thank you.
Thanks, Varun. Sir, please.
Very well discussed. A good revision of nephrotic syndrome. As Abhishek's question that how much diuretic you should give. Any nephrotic we admit in pediatric, or you don't give diuretic upfront. We first tell them to check the pulse and BP, whether they are volume depleted or not. Steroid-induced diuresis starts within 5 to 7 days. Sometimes, if the child is okay, good pulse volume, no oliguria, with steroid only after 5 to 7 days they start diureting. So if they're not, then we give that iloin Lasix combination. Secondly, the definition of resistant is 6 weeks of 2 mg per week, not 4 weeks. Recent definition is changed.
Six
6
weeks.
weeks of
Sir,
day.
is it late responder? Because that was
That
also
is
my
that. That
impression.
is that. Initially, when you were a student, it was 4 weeks.
Yes,
Now
sir.
it is 6 weeks.
Sir, KD ko.
And thirdly, they're more prone to infection, not due to only loss of immunoglobulins in urine. It is also due to their giving heavy steroids as well as other
Yes.
sparing agents.
Yes, sir.
Thank you.
Thank
Very well
you, sir.
discussed, sir.
Any other comments, sir?
Yes, a very well discussed thing. One final question for the biochemistry resident and the physiology resident. What happens to insulin in nephrotic syndrome? Insulin synthesis, insulin excretion, and insulin sensitivity. Any comments? Or if you don't know, you can read it up and then you can. Anybody, like any other resident, medicine resident can think what will happen in nephrotic syndrome, or nothing will happen.
You got the question? Final years. What happens to insulin sensitivity?
Sensitivity, production, excretion in nephrotic syndrome.
No, sir.
Thank you. Thank you.
Thank you. With this, we come to the end of the session. Thank you.